Hi there, this is James, and today we're going to talk about celiac disease, an autoimmune disorder triggered by gluten consumption. This actually affects many people worldwide, yet many do not realize they have it. It causes damage to the smaller intestine, leading to many digestive symptoms, fatigue, and skin rashes. So, an early detection and raising the awareness about celiac disease is crucial to help individuals better understand their health and make necessary lifestyle changes. So let's get started. But don't forget to like, share, and subscribe for more content on health. Let's take a brief look at some pathophysiology. Celiac disease is a chronic disease. It is also an immune-mediated disease of the smaller intestines as a result of the sensitizing effect of gluten-derived peptides from diets such as wheat kernels, rye, barley in a genetically susceptible individual. So this is a patient that suffers from celiac disease, may not be aware, and they have ingested a food that contains gluten. Gluten is made up of two protein molecules. One of them, as you can see, a rod-like shape. We're going to call that glutenin, which actually has a bigger molecular weight than its other component, which is called gliadin right there. So this is gliadin. Gliadin is very important to us today because it is a tough peptide that can actually resist enzymatic degradation. Gliadin somehow has to translocate from the lumen of the intestine into the lamina propria. So how does it do that? Well, gliadin can actually move across the cell, and we're going to call that transcellular. Or it may move in between the cells, and we're going to call that paracellular pathway. Whatever be the pathway, gliadin finds its way into the lamina propria. But what happens exactly is that gliadin binds to a receptor, for example, called CXCR3. When this interaction occurs, there is the release of something called zonulins. So zonulins are a part of the intestinal tight junctions. And as you recall, the tight junctions, it makes up the intestinal epithelial barrier that prevents certain macromolecules from getting into the lamina propria. So the interaction between this receptor and gliadin right here, as you can see, this leads to a release of zonulins, and zonulins increases gut permeability so that gliadin then translocates across the cell, either transcellular or paracellular, and it finds its way into the lamina propria. Now, it's important to also say that this receptor right here, which is CXCR3, seems to be located or expressed in this part of the cell, that is the lumen, and it could be absent in the lamina propria. It could also be that it is used to flush out antigens and bacteria from the lumen so that in the lamina propria, the immune system can deal with such antigens. Well, further, so what happens when gliadin enters the lamina propria? This is gliadin, and when it enters the lamina propria, it is actually deamidated. An amide group is removed from the gliadin with the help of a very important enzyme, which we're going to call tissue transglutaminase 2. So this is very important because this enzyme can also be targeted in celiac disease by autoantibodies. So the deamidated gliadin is then picked up by antigen presenting cells. Now you recall antigen presenting cell can actually be a dendritic cell or let's say a macrophage. Now if you remember, macrophages actually have a major histocompatibility complex 2. And if you recall, there is an encoded gene which is an HLA-DQ2 as well as DQ8. So this is what makes the individual susceptible to celiac disease when you inherit any of these genes. So antigen presenting cell, in this case, let's say it is a macrophage, it then picks up the deamidated gliadin and it presents it to the CD4 cells. Now, once CD4 cells gets to also see the antigen, it actually leads to two major pathways, one with the help of T helper 2 cells. So what happens is that there's actually a clonal expansion of B cell lymphocytes, as you can see right there. And this will also lead to the production of plasma cells, and plasma cells will lead to the production of antibodies that will be going to attack this enzyme that we call tissue transglutaminase. The antibodies may also attack the deamidated peptides that you see. Gliadin itself may also be targeted by the antibodies. And also there is an anti-endomysial antibody. So endomysium is just a protein located within the myofibrils of smooth muscle cells of the gastrointestinal tract. So the other pathway is with the help of T helper 1 cells, and this leads to an increased inflammatory cytokines such as interferon gamma, as you see right here, interleukin, for example, 15, as well as 21 may also be expressed, tumor necrosis factor right there. And this enhances, again, release of CD8 cells, as you can see right there. So the effect of this is that this is directed towards the intestinal architecture, that is the smaller intestinal cells. And what happens is that this goes in there to attack the intestinal cells. So what are we going to see? We're going to see distortion of the intestinal cell. For example, the cell itself may decrease in height. You would also see intraepithelial presence of many lymphocytes here. It's only one demonstrated, but you see a lot of lymphocytes in most of the affected cells. There is also crypt hyperplasia. And importantly, as you can see, this is the villus right there. And here you can see there is atrophy of the villus. Now let's look at this part of physiology and apply a little bit of pharmacology. So let's say we put glutenase. What is glutenase? This is an enzyme that can actually digest gluten. This will seem to help the patient. Of course, if we target the paracellular pathway, this would also prevent gliadin from translocating into the lamina propria, and it can also reduce patient symptoms. We could actually also use drugs that can inhibit tissue transglutaminase, and that can also prevent symptoms to a certain extent. And of course, we could also target the CD4 cells so that they could tolerate gliadin much more better than the patient with celiac disease. And of course, we could also target the cytokines, for example, say drugs that will reduce interleukin, say 15, for example. So these are areas that pharmacology could target and help the patients. Clinical manifestation, malabsorption. So patients may complain of weight loss, steatorrhea, abdominal bloating, chronic diarrhea, and foul-smelling bulky feces. Severe malabsorption may also lead to anemia, such as iron deficiency anemia, vitamin B12 deficiency, folic acid deficiency, osteoporosis, coagulation impairments, muscle wasting, neuropathy, and electrolyte imbalance, as well as edema from protein-losing enteropathy may all be seen. Now, it has been shown that some patients with celiac disease actually fulfill the criteria for irritable bowel syndrome. So sometimes irritable bowel syndrome could actually be celiac disease. In 25% of the cases, celiac disease may also present with dermatitis herpetiformis. Celiac disease is much more common in patients with type 1 diabetes mellitus. Unexplained elevated aminotransferase should also seek to exclude celiac disease as a probable cause. So it's important that you remember that in celiac disease, the intestinal brush borders, so if this is the intestine, as you recall, the brush borders produces something called lactase. Right, this is an enzyme that digests or hydrolyzes lactose into galactose and glucose. So celiac disease destroys the cells of the smaller intestine. So it also destroys the brush border cells. And so patients with celiac disease can also have a low lactase enzyme, right? So it's important that when you are treating a patient with celiac disease, you also let them stop taking lactose for the first few weeks, as they would also suffer from lactose intolerance. And one of the ways to also remember diseases that are or disorders that are associated with celiac disease is by writing CHAMP. And then you can then say that C is for celiac disease, H is hypothyroidism, Addison's disease, mellitus, that is diabetes mellitus, and myasthenia gravis can also be affected sometimes, and of course, pernicious anemia. Diagnosis. So the initial test of preference in patients that are older than 2 years is an immunoglobulin A tissue transglutaminase antibodies that seems to have a very good sensitivity as well as specificity. If the patient is deficient of immunoglobulin A, then immunoglobulin G tissue transglutaminase antibodies may also be used. In fact, immunoglobulin A anti-endometrial antibodies have an excellent sensitivity as well as specificity and can be used as confirmatory test if transglutaminase antibodies are positive. Deamidated gliadin peptide antibodies are also useful, but anti-gliadin antibodies are not recommended currently due to its poor specificity and sensitivity. Upper GI endoscopy with a small bile biopsy is the test that will confirm celiac disease. Histology findings may include distortion of enterocytes, such as decreased height and crypt hyperplasia, villous atrophy, and increased intraepithelial T lymphocytes presence. Genetic testing, that is typing for HLA-DQ2 and DQ8, are not routinely used. However, they may be indicated if histology results are normal, but there is still a strong suspicion for celiac disease, or in patients who have followed a gluten-free diet prior to baseline serology testing. Treatment. Well, you need to educate the patient. There should be a strict adherence to a lifelong gluten-free diet. Patients should avoid lactose in the first few weeks of treatment, as secondary damage to the brush border by celiac disease may lead to a lactase deficiency. Refer patients to a registered dietitian for nutritional assessment. Replace micronutrients such as iron, B12, folate, calcium, zinc, and carotene. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.